Yes, Kendra, thank you so much for telling me I'm mute. I'm sitting here talking away. So welcome to week 7. Your exam 3 is going to be week 9. So week 7 and week 8, and then after the week 8, we'll do another exam 3 review. So please, if you can, come to the reviews, just because we highlight the information that it's definitely going to be on the test, and it's a really good opportunity for you to ask any last minute questions. So I strongly encourage you guys to all go to the exam 3 review. If you can't, you can go ahead and watch it, but I think that coming to the review is best, because then you have the opportunity to ask your questions. And then just want to make sure everyone remembers that today is your quiz 4. So we'll take the quiz at the end of class. Does anyone have any questions about the quiz or the test from last week or anything that's going on in the class? Okay, so we're going to start with, the blood conditions. This is going to be anemias and problems with blood forming products. So generally speaking, something that's really important to know about blood disorders is that red blood cells are formed in the marrow of the long bones in childhood and infancy, and then as you continue to grow, they start being formed in other bones. And it's regulated by a hormone. Red blood cell production is regulated by a hormone called erythropoietin. And then you can give synthetic erythropoietin for somebody that has problems making red blood cells. So it's not uncommon, like someone that's on chemotherapy or that has leukemia or something, they can get synthetic erythropoietin, which helps them stimulate red blood cell production. And then, so we have the blood system and we have the lymphatic system. Has anyone heard of the lymphatic system, or what do you think the lymphatic system does?
Doesn't the lymphatic system have something to do with immunity?
It does. Very good. And when do we, when we have lymph nodes, when do we have swollen lymph nodes?
When you're infected with a virus or a bacteria that your body's trying to fight off.
Yeah. So your body drains fluids throughout your body into your lymph nodes, and then if you have an infection or something like that, then they'll become inflamed. And then there are the spleen is also part of the lymph system, and the spleen produces lymphocytes, and it also produces some antibodies. So you'll talk about the spleen and the lymph system, going together. And you think about, it's never normal to have enlarged or swollen lymph nodes. So if you're ever doing a physical exam on a patient, pediatric patient in particular, it's never normal for them to have enlarged lymph nodes. So if you have an enlarged spleen, that's called splenomegaly, and you can see this in a couple of different conditions. Like you can see it with sickle cell anemia, you can see it with Cooley's anemia, you can also see it when during infections. So just to kind of remember that the spleen and the lymph system go together, and the lymph system is about draining fluids through the body, and it's also involved in your immune system and helping you fight infections. And then in terms of the blood, we have the plasma, and then we have what are called the formed elements. So the plasma is mainly water, but then it also has albumin and gamma globulin and hormones and stuff like that. But when we talk about the blood, like when we give packed red blood cells, we're giving erythrocytes. So the plasma is kind of the water, and the parts of what's circulating in your vascular system that aren't really considered blood cells, and then the formed elements are more of what you consider, your blood cells. So erythrocytes is just another term for red blood cells. Leukocytes is another term for white blood cells, and then thrombocytes is another term for platelets. So you should know all 3 of these words and know what their synonym is, because they're used interchangeably. And they're not trying to confuse you. It's just that the erythrocyte is like the medical term for red blood cell. So these 3, erythrocytes, leukocytes, and thrombocytes, they're what are called the formed elements. So they're not part of your plasma, they're the formed elements of your blood. Oh, I went the wrong direction. Sorry about that. So anemia is just a reduction in the amount of circulating hemoglobin. So what blood cells have hemoglobin? Where is hemoglobin located?
Red blood cells.
So your red blood cells. So hemoglobin is the oxygen binding protein that's on your red blood cells. So you need hemoglobin, and then you also need red blood cells, but they're combined. The hemoglobin is on the red blood cells. So you need the hemoglobin to carry oxygen throughout your body, and you need iron to produce hemoglobin. So iron deficiency anemia is that you don't have enough iron to produce an adequate amount of hemoglobin, which is the protein on the red blood cell that binds oxygen. So what type of symptoms do patients have if they have a low hemoglobin?
Fatigue, like
Yeah.
they get tired very easily.
Yeah, think about how you would feel if you didn't have enough oxygen, right? Because if you don't have enough hemoglobin, you don't have the same ability to transport oxygen throughout your body because the oxygen binds to the hemoglobin. So weak, being kind of restless, irritable. Over time, it can lead to congestive heart failure. Your heart pumps more blood, you have a higher cardiac output to compensate for the fact that you have a low hemoglobin. So, usually kind of early on, if you're anemic, you'll be that irritable and tired, maybe a little bit weak, but then over time, you end up developing signs of heart failure, which can then lead to shortness of breath and tachypnea. So it's anemia, especially iron deficiency anemia is easily treated, but just to remember that it can have serious consequences if it's not easily treated. So iron deficiency anemia is the most common type of anemia. And there's certain things that can make or kind of cause kids to develop iron deficiency anemia. And one of the main ones is giving them cow's milk. So we talked earlier, like when do you start introducing cow's milk to children normally? When do we recommend?
1 year old.
1 year old. And what could go wrong? Like, why is giving it earlier a problem? Like a 8-month-old or a 9-month-old?
Their body can't digest the lactose that early.
Yeah, and it can cause irritation, and then it can cause microbleeding. So cow's milk decreases the absorption of iron from the GI tract, and it also can be irritating and cause bleeding, which can exacerbate anemia. So the main reason is that cow's milk can lead to GI bleeding, which can lead to anemia, and also there's a decreased iron absorption. So it doesn't, cow's milk doesn't have all the nutrients that kids need, or babies need specifically, and then also it can contribute to iron deficiency anemia. So Walter knew this. So these are the manifestations. You're irritable, pale, decreased activity are the main things that you see. Some sorts of things that you will test for, you'll look at their blood cell count, their hemoglobin and hematocrit, their iron levels, and you might test their stool or their poop for occult blood, because if you're losing blood and iron, that can make your iron deficiency anemia worse. So when they're trying to find out a cause, these are all the different labs that they tend to run on children. And I mentioned this earlier, that if it's untreated, it can lead to really serious consequences. Straightforward iron deficiency anemia, you just give ferrous sulfate 2 to 3 times a day. Vitamin C aids in absorption. So if they're old enough to take orange juice, it's good to take your iron supplement with orange juice. And if they're not kind of at the age that you would give it on an empty stomach when their acid concentrations are the highest. And then if possible, breast milk, we still always recommend, if possible, that moms breastfeed at least for the first 6 months. And then iron fortified cereal for the first year of life, and no cow's milk until they're 12 months. So a form of anemia that's not related to your diet, but is genetically inherited, is sickle cell disease. Has anyone heard of sickle cell disease or have any information about what sickle cell disease is? I see Reese kind of nodding her head. Have you, and Walter too? Okay, Reese, go ahead and tell me what you know about sickle cell disease.
So pretty much their red blood cells are shaped wrong.
Okay.
So when they hit on the sides of the blood vessels, it's very painful. So you want to, like when a child is in sickle cell crisis, you want to just overload them with fluids
Okay.
to try and limit how much pain they're in.
Yeah. So the sickle cell kind of gives you an indication of a lot of what's going on. It's shaped like a crescent, so it's not round. It's shaped like a crescent. They form clots more easily. So Reese talked about like it's painful. Part of the reason why it's painful is they stick together and they form these clots. And so then blood can't get around the clots, and the lack of blood flow to the microvessels can cause a lot of pain. So Reese is right. One of the main things you do is you give IV fluid to make sure their blood is not viscous, not too thick, and it's able to pass through those clots that form. And it's genetically inherited. So to have true sickle cell disease, you would have to inherit the gene from both parents. But you can have sickle cell trait, where you get the gene from one parent, and then you have some that are normally shaped and some that are abnormally shaped. So if you have sickle cell trait, you might be asymptomatic. You might not have any symptoms of anemia, or you could have some milder symptoms. And does anyone know the ethnic group that's more likely to have sickle cell disease?
African American.
African Americans. Very good. So sickle cell disease is something that you will definitely be tested on. And there's some key points. A lot of them Reese kind of brought up, that the cells are misshapen. It can be very painful. So they can have what's called this vaso-occlusive crisis, which is what's painful. So that's when their cells are misshapen, so they form clots more easily, and it gets stuck in their small vessels and the blood can't get through, and that's very painful. And then there's splenic sequestration. So we talked about the spleen being part of your lymph system. It's the same thing, where the misshapen cells get stuck in your spleen. They can't make it all the way through, and then your spleen ends up getting enlarged. Aplastic crisis is oh, I'm sorry, just a second. Hey, Joaquin. Sorry. I have none of my dogs are letting me know that my neighbors are home. I apologize for that. So aplastic crisis refers to like a bone marrow crisis, where the bone marrow isn't producing enough cells. And then hyperhemolytic, this is like an autoimmune reaction to break down blood cells. And sometimes this happens, kids that have sickle cell anemia, they will sometimes get blood transfusions so that they have more normally shaped hemoglobin. And then there can be like an autoimmune reaction where they break down all their blood cells, and then they can go into a crisis because of the massive destruction of red blood cells. So we talked briefly, erythropoietin is a naturally occurring hormone. You normally produce it, that helps stimulate the red blood cell production. So you can give synthetic erythropoietin to children with sickle cell disease to help them produce more red blood cells. They can also do chemotherapy that affects their production of red blood cells. Sometimes they do a splenectomy, but not very often. Usually the blood cells will get sequestered there, and then if over time the spleen might just not stop functioning, but they don't necessarily have to do a sequestration, or they don't necessarily have to do a splenectomy. And then Reese mentioned here some key needing points is to prevent infection, make sure they don't get dehydrated. So one of the things with sickle cell, if you're ever given like a priority nursing question for a sickle cell patient that comes in, is you place an IV and you start them on IV fluid. They might need extra oxygen, so avoid hypoxia. And this hemodiasterus, this refers to, iron deposits throughout the body. So when red blood cells are broken down, they release iron. So then you can end up with this iron buildup that causes problems. So you can give defermexamine to break down the iron that builds up as a result of the red blood cell destruction. So another type of anemia that's genetically inherited is called thalassemia. So it's similar to sickle cell disease in the sense that if you inherit the gene from both parents, then you develop the thalassemia major, which is also called Cooley's anemia. And if you only have the gene from one parent, it's called thalassemia minor. And people with thalassemia minor might not even have any symptoms of anemia. So it's the same thing. They're not sickle shaped, but they're not shaped correctly. So they don't have the same oxygen carrying capacity as patients that don't have a thalassemia. And it is primarily treated with blood transfusions throughout their lifetime. And they are also at very high risk for that iron buildup in different organs. And the main thing to recognize, I would say, is that, the thalassemia minor is when it's just one, and early on they might misdiagnose it as iron deficiency anemia, but they can have a pretty normal life. Whereas the thalassemia major, they're usually diagnosed in the first year. They have really pronounced anemia and they require a lot of blood transfusions. So this is the slide on thalassemia major. So it's much more severe, and they need a lot more care over time. So whenever you're talking about either thalassemia major or sickle cell disease, think about, like, as a nurse, what you would do for somebody that has a chronic illness, supporting the entire family, preparing them for like lifelong care, teaching them about like possibility of frequent hospitalizations and what the hospital will be like, etc. So are several slides on here on the thalassemias. I'm going to skip over them because I know that they're not going to be super heavily tested. You need to recognize the difference between major and minor, and recognize, the treatment, what the treatment is, and sort of nursing care for both of those. So another sort of blood disorder you can have is hemophilia, which just refers to the inability to clot normally. So this one is different. It says here it's transmitted by symptom-free females. So there's two possible chromosome configurations. You can be XX or XY. Does anyone know what boys are? Are boys XX or XY? They're XY. Very good, Reese. So hemophilia is transmitted by symptom-free females. Do you think hemophilia, you see it in boys or in girls?
Boys.
So you're going to see it in boys. So boys are XY, and the gene for hemophilia is carried on the X chromosome. So the mom carries the gene and she doesn't know it. She's totally asymptomatic. But then she has a boy whose chromosome is XY, and then it's not carried on the Y. So if you only receive one on your X because you're a boy, then you'll have the disorder. Whereas a woman would need to have received the XX from both parents, which is very, very rare. So it's going to be in the boys because it's going to be passed on the X chromosome from mom to the boy, and then the boy doesn't have to get a second copy of the gene from the dad because it's only on the X chromosome, and boys are XY. So this is a little bit of an unusual in terms of a genetic pattern. So to kind of remember that it's passed on the X chromosome, so it's going to be passed from the mom to the son. And the main treatment for hemophilia is to replace the clotting factor that's missing. So there's multiple different types of hemophilia, and you'll identify the specific clotting factor that they don't produce, and then you give them that clotting factor. And there's a wide range of hemophilia. So sometimes, sometimes it's really, really mild, and sometimes they can bleed to death. So you do need to, firmly establish what type of hemophilia they have, how severe it is, what their clotting ability is, and then make sure that they get the correct clotting factor as a replacement. So this is kind of emphasizing that point. So normally your blood would clot in 3 to 6 minutes, but in severe hemophilia, it can take an hour or more. So obviously, if you normally clot in 3 to 6 minutes, if it can take an hour or more, you can bleed to death in that hour. So, and this is kind of a side note that clotting factors, clotting factor 8 does not cross through the placenta to the fetus. So when the baby's born, you can test them right away because they're not going to have any of their mom's circulating clotting factor. So you can test babies right away if there's a family history to see if they have hemophilia. You can test them right when they're born. So obviously the main thing is bleeding. You're going to worry about, why would you worry about a severe headache, vomiting, and disorientation? Why would that be a red flag with someone that has hemophilia? What does that sound like it goes with?
Hemorrhage?
Vomiting, headache, huh?
Oh,
The flu?
Might be the flu. We talked about the neuro, like vomiting, headache, Cushing's triad. What does that go with?
It's not a concussion, right?
No, but it could be a brain bleed. So if you have increased intracranial pressure because you're bleeding into your brain, so you could have a severe headache, vomiting, disorientation. So since these kids are at risk for bleeding, you have to be worried about bleeding everywhere. Into their brain is going to be the most dangerous place, because then they can have a cranial hemorrhage. So in the milder cases, parents might call and be like, he has this nosebleed that just won't stop. I put pressure on for 10 minutes and it's still bleeding. Sometimes they have joint pain, so sometimes the first thing that they end up having is like some bleeding into their joints. So just to kind of remember that parents usually know their kid really well. And if they say something that's off, like they really get a lot of nosebleeds, you really need to follow up on that, because that could be like a mild hemophilia that needs to be worked up and diagnosed. So, and I did talk about this, the main thing that you do is you prevent the bleeding by giving them missing clotting factor. Depending on, there's multiple different clotting factors. So DDAVP can be used in mild hemophilia because it stimulates the protein that carries factor VIII. So this is an option for some hemophiliacs, and this is just a nasal spray, which is nice because a lot of the clotting factors have to be given IV. So, they're almost always going to have a hematologist that is helping manage them. They're going to have a multidisciplinary team. They have to be prepared this chronic illness. They're going to get treatment throughout their life. It's not going to get better. They're going to need to have that clotting factor replaced throughout their life. And then platelets, another part of our blood system. What is the primary purpose of platelets? What do platelets do in our body?
They clot.
Help your blood clot.
Help your blood clot. Very good. So these words here are all describe different things you could see on your skin that are related to not forming clots. So petechiae are just little red dots, and purpura are big petechiae. So purpura are greater than 4 millimeters, and petechiae are smaller than 4. So they're really kind of the same thing. They're broken blood vessels that you see on the skin. And then ecchymosis is that coloration of bruising, and then hematoma is actual swelling. So all of these things are associated with not forming clots that you might see if you have a problem with your platelets. So the most common platelet disorder in kids is something called ITP, which is idiopathic immunological thrombocytopenia. So this is like, an autoimmune reaction, often following a viral illness, that causes the body to attack its own platelets. So when kids have ITP, their spleen sequesters and attacks platelets, and then they end up with a low platelet count, and they're at higher risk for bleeding. So, the main thing you're going to see is signs of bleeding. And like I said, it's not uncommon that it follows a viral infection. And usually they're going to be, the plates will be quite low, around 20,000, when it's normal to have like 150 to 400,000. And they can do definitive diagnosis with a bone marrow aspiration. So this is another one. So we talked about with hemophilia, you worry about headache, vomiting. Why do you think neurological assessments are a priority of care in someone that has ITP? It's going to be very similar to the reasons why we monitor neurological status in kids that have hemophilia. What do you think might go wrong?
You want to make sure they're not bleeding in the brain.
Yeah, you're going to want to make sure they're not bleeding in the braid. So this is always going to be, you know, in a nursing priority, a question if you have a patient, regardless of why they're bleeding, hemophilia or platelet destruction, low platelets, you need to be doing frequent neurological assessments. It's treated with your basic autoimmune, sort of prednisone, etc. And sometimes they can not, usually they come in, they get some prednisone, they get over their viral illness, and then their body stops attacking their platelets. But you can have chronic ITP, and then they can do a splenectomy in that case, because the spleen is where the platelets are normally destroyed. So there are certain medications to avoid when you have ITP. So I just put on here, because I didn't recognize, I had to look these up. So these are both NSAIDs, but they're no longer on the market. So I don't really know why they're still mentioned in your textbook. So you are probably never going to have a patient on these two medications, but they do decrease platelet aggregation, but they're not on the market anymore. So aspirin decreases platelet aggregation, and so does caffeine. So these medications are going to make you more likely to bleed regardless of what's going on with your platelets. So that's why you want to avoid them if they have ITP. You don't normally give them a platelet transfusion because they're having an autoimmune reaction where they're destroying platelets, and they'll destroy the platelets that you transfuse. So you mainly do symptomatic management and try to tamper down their immune system so that they stop destroying their platelets. So there are certain things, you know, when you increase risk for bleeding, again, bleeding in your GI tract, hemarthrosis, that's bleeding into your joints, intracranial hemorrhage, bleeding into your brain, and then making sure that kids are up to date on their immunizations is one way that you can prevent ITP, because it normally follows a viral illness. Does anyone have any questions on that information? All right, so I'm going to give you guys a couple of, let me open this over here. Questions that I want you to talk about as a group. Let's see here. And then we'll do a quick Kahoot, and then we'll do the next chapter. Thankfully, the PowerPoint slides they're not too long this week. Put this over here. Okay, so I'm going to give you guys, it's about 9:30, so I'm going to give you until 9:45 to answer these questions. And we'll talk about them as a group. Let's see here. Oh, okay. So review the effects of severe anemia on the heart. Recommend 4 food sources of iron with a child with iron deficiency anemia, and explain the pathophysiology or the pathology and signs and symptoms of sickle cell disease. So you have 3 questions. I think there's just 15 of you in class today, so you guys can talk amongst each other. Is anyone willing to be the reporter, to come back to class and tell me what you guys talked about? It's brave enough to talk on Zoom. If not, I can ask one of you nicely to do it.
I'll do it.
Thank you very much, Reese. So I'm going to give you guys 15 minutes. I'm going to be here, so if you need anything, you can let me know, but I'm going to let you talk amongst each other, and these are the 3 questions that I want you guys to talk about.
Can
Okay.
you can you repeat the questions? It's not coming up on my screen.
Okay, sure. So the first question is, what are the signs of severe anemia, and how does severe anemia affect the heart? The second question is recommend 4 food sources that are a good source of iron. And then the third is explain the pathology and signs and symptoms of sickle cell disease.
Thank you.
You're welcome.
Reese,
Tiff.
when it comes to the food, I'm thinking more so like fortified cereals. I'm trying to think of what we've done in class.
Leafy greens, aren't they higher in iron?
They are, but is that in
Eggs.
children?
Well, you could always sneak the leafy greens into like a smoothie or something. They don't have to look at it to get it.
I think would pastas or like breads be included in that one as well, since they have like grain?
Our most revered ancestor suddenly was scholar, poet, and inventor of
Beans,
animals.
spinach, eggs. My kids love eggs.
Eggs is another good way of having them.
Agriculture and mischievous nature. Ever since
Dried fruit is another good one.
There you go.
Dried fruit. Perfect. All right. So I have fortified cereals, leafy greens, eggs, and dried fruit for the 4 foods. There's a lot more, but we only need 4.
And then the effects of severe anemia, it could cause tachycardia and increased stroke volume that could lead to a heart attack.
Okay.
Right.
And then the sickle cell disease, it's abnormal red blood cells that get clumped together at extremities, more likely in the lower extremities. So you would see pain in the joints of like the toes and the ankles and the knees. It's very painful. It's their number one symptom, but if they were hospitalized with a sickle cell crisis, you would need to hydrate them, oxygenate them, and control their pain.
You mean Miriam? That girl is
All right.
So I don't hear as much talking. Does that mean you guys have already answered all 3 of them?
Pretty much.
Pretty much. All right, great. So what did you come up with for your sources of iron?
So fortified cereals, leafy greens, eggs, dried fruit. I mean, a lot of people gave out a lot of different ones, but I just focused on 4 that you could probably get a kid to eat.
Yeah, very good. And sometimes it's tricky, like the egg yolks have good iron, but the egg whites don't. So just to kind of remember that if you're ever specifically asked about egg whites. Bran is another good source. I mean, if you can make like bran muffins or something like that, bran and wheat germ. And then meat, right? Like things like liver, not that kids would eat liver, but you know, hamburger, stuff like that also has iron in it. And then what is like, how does chronic anemia affect the heart?
So somebody had said that it could cause tachycardia and increased stroke volume that could lead to a heart attack.
Heart attack, yes, not as likely in a kid, but certainly congestive heart failure. And then when you have congestive heart failure, what sorts of lung or respiratory symptoms might you have?
Then there would be like fluid in the lungs, so they would have difficulty breathing.
Yep. Tachypnea, hypoxia, difficulty breathing. Yes. And then in terms of the sickle cell disease, what did you guys say was the pathology and signs and symptoms of sickle cell?
So there are abnormal red blood cells that clump together.
Okay.
It's typically in the lower extremity, somebody had said. So you'd see like pain in the toes or the feet first.
Okay.
It's very painful during a crisis, so you want to
Mhm.
hydrate them, oxygenate them, and control their pain.
Very good. And if you only receive the gene from one parent, how would that affect you?
Yeah,
then
You
you're
they
just
could get it or you don't get it.
Yeah, so you can have sickle cell trait when you
Yeah.
only have it from one, and then it's the symptoms, there's a wide variety. Sometimes you have more, of the misshapen cells than others, but to have sickle cell disease, you need to get it from both parents. You have to inherit it from both. All right, very good, you guys. So we're gonna do a quick Kahoot, and then we'll do the next bit, the next chapter on the GI stuff. Let me pull up the Kahoots here. Okay, we'll go ahead and get started. So what food is rich in iron? Banana, carrot, cream of wheat, or egg whites? Right, so this is a tricky one. So egg yolks are rich in iron, egg whites are not. So cream of wheat and bran are both good sources of iron. Which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? I give her a cracker to chew on. Formula is too expensive, so we use cow's milk. She eats a lot of fruit, or she almost never drinks water. Right, very good. So this is why one of the main reasons we don't give cow's milk to kids under a year, increases their risk of anemia. So what should the nurse closely assess in a child receiving a transfusion? Lethargy, fever, jaundice, or bradycardia? All right, so this one was a little bit trickery for you. So when you have a transfusion reaction, one of the first things you're going to see is a fever. You wouldn't necessarily see bradycardia. Fever, tachycardia, itching, lower back pain are some things that you might see with a transfusion reaction. So you're going to be keeping a close eye on their vital signs, in particular if they have a fever. So the child receiving a transfusion complains of back pain and itching. What is the best initial reaction by the nurse? Disconnect the IV, clamp off the blood, and run normal saline through the IV. Notify the charge nurse or give Benadryl. All right, so this is a little bit trickier. I mean, I understand why a lot of students would be torn between disconnect the IV and clamp off the blood and run normal saline through the IV. What this is trying you to get at is that you want to make sure that you have a patent IV in case they are having a transfusion reaction and they need some emergency medication. So I think these two should be your top choices, but you're not just going to disconnect the IV. You're going to go ahead and run normal saline through that line to make sure the line stays open. And you're going to do that before you notify the charge nurse, and you're going to need an order for Benadryl, and you don't really know what's going on. So you're going to do this first, where you clamp off the line and then run normal saline. You are probably going to notify the charge nurse and give the Benadryl. But your highest priority is to stop giving the blood and to make sure you keep the IV patent and run saline through it. So the nurse notes that a 4-year-old child has bruising and petechiae on his extremities. What lab value does the nurse suspect? A leukocyte count of 14,000, a hemoglobin of 8, a hematocrit of 36%, or a platelet count of 25,000. All right, so the oozy, your petechiae and bruising, you're worried about bleeding. So you are going to be concerned that there's something wrong with their platelets that's preventing them from clotting. So then they're going to have the petechiae and the bruising. So, I do understand a couple of you chose the hemoglobin because you're having bleeding, but this is trying to get you to think about, like, when you're seeing the bruising, you're worried that they are bleeding and that what would cause that would be the low platelets. Oh, sorry. So a child is diagnosed with iron deficiency anemia. What will the nurse explain can occur if the disorder goes untreated? heart failure, pulmonary embolism, infection, or hemorrhage. Very good. Heart failure. This is what you worry about. Their heart has to pump harder because they don't have the same oxygen carrying capacity that can lead to heart failure. A child with leukemia has a platelet count of 19,000. What is the priority nursing intervention? Place a PIV, assess the neurological status, monitor vital signs during the platelet transfusion, or educate family on preventing bleeding. All right, so this is always going to be the platelet count of 19,000. That's low. You're worried that they're going to bleed, so you're going to do the assess the neurological status is going to be your priority. You very well are going to be doing these other things, but your priority is going to make sure they're not having a brain bleed. So always remember, if someone's at increased risk for bleeding and you're asked to prioritize your nursing care, you're going to be doing neurological evaluations. So what would the nurse include in a teaching plan about a mouth care for a child receiving chemotherapy? Use a soft toothbrush, avoid a water pick, inspect mouth weekly for ulcers, or use a commercial mouthwash. So very good. Yeah, you do want to use a soft toothbrush. You might use a water pick to kind of help get some stuff out. Weekly for ulcers, that you need to do more often than that. And you're going to use like a special mouthwash that's not irritating to their mucosa. So the best answer for sure is to use a soft toothbrush. So an adolescent with Hodgkin's disease is crying and states, "I'm so scared." What is the best response from the nurse? You shouldn't feel that way. I understand how you must feel. Tell me what got you so scared, or you should talk to your parents, not me. Yeah, so very good. You want to open up the conversation, get her to tell you what's going on. You don't want to shut down her feelings at all. All right, last one. The nurse is caring for a child with a low platelet count. What skin assessments would alert the nurse to bleeding? Ecchymosis, hematoma, petechiae, or all of the above? Yep, all of the above. Good job, you guys. All right, who is Jay?
Me,
Jay, could you go ahead and tell me your name?
Joelle,
Joelle, very nice, Joelle. And how about two?
Celeste.
Foley. All right, very, very nice. All right, good job, you guys. So next we are going to go ahead and look at the next PowerPoint. Okay, So in this section, we're going to talk about vomiting, diarrhea, and then some problems that kids can be born with that affect their gastrointestinal tract. So, just to kind of remember that your GI tract really is from your mouth all the way to your anus. So it's a pretty big organ system. And it's really mainly responsible for breaking down what you eat into something that's absorbable and, then can be used for your body. So there are some, when we talk about systemic, we're talking about things that you can see that affect your entire body, and then versus local science, localized. So failure to thrive is something that you might see if you're having a problem with your GI tract. And then something that you don't think about that often, but is possible, is itching. And if you have like liver dysfunction, then you can end up with pruritus and itching. So just to kind of remember, sometimes you'll see something kind of vague, like they're not gaining weight well, or they kind of have this itching and you don't really know why. And that could actually be a sign that they're having problems with their GI tract. Things that you think about more commonly is going to be pain, vomiting, diarrhea, or constipation, rectal bleeding, or hemoptysis, which is just vomiting blood. So, your primary nursing interventions are going to be making sure they're getting adequate nutrition, and making sure that if there's any developmental delays, that they're being investigated, paying attention if they're itching, having changes in their bowel movement, and addressing their pain and discomfort. So always thinking about the whole patient, not just whatever their presenting symptom is. So there's congenital disorders. Does anyone remember what congenital means?
It's like genetic.
Genetic, or you're born with it specifically. So congenital means that you were born with a condition. So it's present from birth. So a GI condition that you can be born with is esophageal atresia or transesophageal fistula. So when you look in the back of the mouth, the esophagus and the trachea are two tubes. One goes to the lung and one goes to the stomach. And so if you have esophageal atresia, that means the esophagus doesn't connect to the stomach. Or transesophageal fistula, there's a connection between the trachea and the esophagus. So both of these are problems that you can see at birth, or that you will see at birth. They're born with. It's not something they develop over time. What do you think a child that had one of these conditions, what would you see in them? If you're imagining that there's like a communication between the trachea and the esophagus, or if the esophagus doesn't attach to the stomach, what would you see in the kid? How would the kid respond when they fed?
Poor appetite, probably vomit a lot.
Coughing too, right? Because they're, especially when there's a connection between the trachea, then they could be aspirating into their lungs. So they're going to be coughing. So if they're diagnosed, then they're made NPO and then they have surgery. So this is something they're going to repair as a newborn before they go home and start eating. So another problem that babies can be born with is called an imperforate anus. So that's where the lower GI and the anus don't connect. So you're not able to pass stool from your GI tract out your anus. So it can be completely not connected, or it can be narrowed. So you're going to have to, evaluate them thoroughly, but this is something where they're going to need surgery to help them be able to pass stool out their anus. Sometimes they'll do a colostomy instead of just doing the surgery right away. So there's a couple of different things that you're born with that you might see because they don't pass meconium in the first 24 hours. So if I were you and I were taking notes, I would make a list of like symptoms that present, or symptoms that or diseases you would be worried about if the child did not pass meconium in the first 24 hours, because you could see that again on a test question. So for sure, one of them is imperforate anus, where they don't pass any stool because they don't have a connection between their anus and their intestines, so they're not able to pass the poop out of their body. So meconium is just, that first dark poop from, that they have in their GI tract when they're born. Before they even eat, they should still pass meconium. So just to remember that you always keep babies in the hospital until they pass that first meconium stool, because if you don't, there's something going on with their GI tract that you need to follow up on. So once you figure out that they have an imperforate anus, you're going to make them MPO. Like I said, sometimes they do a colostomy. Does anyone know what a colostomy is? What is a colostomy?
That bag. That
Yeah. Yeah. Where do you put the
they-
bag?
on your stomach, your colon, they like protrude your colon out.
Yeah.
So
They pull your colon up to your skin, right? So they create like your colon can drain out your abdomen in essence. And then you have like a little, you see like an outpooching of the intestine, and they put a bag around that outpooching. So the stool will then drain through the colostomy into a bag. Very good. Something else that, you know, kids can be born with is pyloric stenosis. Has anyone heard of pyloric stenosis? Or had a family member or somebody that had it? Nobody? So the pylorus is the connection of the stomach to the small intestine. So if you have stenosis, is that connection too big or too small?
Small.
It's too small. So you're not able to pass the food from the stomach down into the small intestine. So you have this projectile vomiting. So it's nothing like a kid that has gastroenteritis. It's like it hits the wall. It's very projectile. And the kid generally feels okay, right? I mean, they're hungry, they don't have a fever, they don't act like a kid that has a viral illness. So they eat and then they puke and then they're hungry right away. Sometimes you can actually feel this olive-shaped mass in the abdomen in the right upper quadrant. So this is something that is going to require surgery. You're going to make them NPO until they get their surgery, and then they'll have their pyloric stenosis fixed. Kids can also have celiac disease. Has anyone heard of celiac disease?
Heard of it.
I think Walter might know.
I seen that diagnosis many times, but I just can't remember what it is. So
Oh, okay. So it's when they're gluten allergic, they can't digest gluten. So then they have problems with absorption from their GI tract.
oh,
So they have to avoid all of these foods: wheats, barley, oats, and rye. So it's hard for a kid to have a celiac disease because a lot of the food that kids eat contains gluten. So the only real treatment for celiac disease is to avoid gluten. So if they have celiac and they are continuing exposed, and they end up with damage to the villi of their intestine, which leads to malabsorption. So they can end up with abdominal distension and vomiting. So, you know, there's a lot more recognition that there's people out there that have celiac disease now. So you're going to see more gluten-free products and stuff like that. It is important to remember that not everyone that has celiac disease has the same symptoms. So like the classic is they have abdominal pain, diarrhea, and malabsorption. The silent is, although they have like this inflammation, they don't really have the classic symptoms. And then the atypical, they're more like tired, they don't feel well, they develop anemia, but they don't necessarily have the abdominal pain and the diarrhea. So the most common is just going to be your basic diarrhea and abdominal pain, but it can present differently in different children. And then latent just means they don't really have the GI symptoms, but they have this rash that won't go away. And then, so for some kids, they'll have like this rash that won't go away, and then you'll take gluten out of their diet, and their rash gets better. So as you can imagine, if they have failure to, you know, if they have malabsorption, they could have failure to thrive. They're irritable. Since they're not absorbing well, they're going to have large, bulky, frothy stools. They can do the serum immune globulin A and a small bowel biopsy this is how you would definitively diagnose it. And you have to remember that the treatment, there isn't like a medication that they take that makes it better. They just have to avoid gluten. So they're going to have a gluten-free diet. So they very often work with the nutritionist to identify a diet that they can eat that's gluten-free. So Hirschsprung's is another problem with your GI tract that you can be born with. This one is associated with Down syndrome. So kids that have Down syndrome are more likely to have Hirschsprung's. And it's a problem with the nerve stimulation to the bowel. So they don't have the same peristalsis, or they don't have the same movement of their bowels, so they end up getting constipated. And since they have that lack of movement of their bowel, when they do pass stools, it can be like this very, very narrow ribbon-like. And it can be acute or chronic. This is another one, if you were to make your list of things that you would suspect if they didn't pass meconium in the first 24 to 48 hours, would be Hirschsprung's. So imperforated anus and Hirschsprung's, you might first pick up on both of those because of their failure to pass a meconium stool. So sometimes they require surgery, sometimes they don't. Sometimes it can be managed with, just treatment of their constipation. So it can lead to obstruction, which then can lead to more problems. So just to remember that, it can be serious. Like I said, it can be acute or chronic, and there's a variety of symptoms. But if they develop the intestinal obstruction, they can then get translocation of the bacteria into their bloodstream, and they can develop toxic shock, and they can be very sick. And then, there's a couple different things that they can do, including like a rectal biopsy or an anal rectal manometry, which is kind of just measuring the pressure in their anal sphincter. And then Meckel's diverticulum. So this is going to be like an outpoaching of the small intestine. And it usually occurs at the ileocecal valve. And this little pouch is subject to inflammation. So the most common thing that you see with this is GI bleeding. And it is something that you treat with surgery. And then hernias. Has anyone known an adult that had a hernia?
Myself.
Yourself. All right, Walter. So did you have an inguinal hernia? Where was your hernia?
Inguinal, and I had one, and then the other one came out also.
Okay.
So I had two surgeries.
Oh my goodness.
The first one, I got sick. I ended up in the hospital with inflammation in all the liner of my stomach.
Oh, wow. So, Walter, what would you say in general? What would you say like the general definition of a hernia is?
Well, it's like it will like mine was like strangulation.
Oh, you had a strangulation, so yours was more serious. Okay.
Yeah, and apparently I didn't realize it. So it was like I was having a lot of like nausea, vomiting, and stuff like that, abdominal pain.
Uh-huh.
I wasn't aware of what I had. They thought it was an appendicitis.
Oh.
So when they took me for a laparoscopy, they found out that it was a strangulated hernia.
So generally speaking, a hernia is when like abdominal tissue or fat bulge through the muscle wall. So you usually see like an outpoaching. You can usually see a hernia. So they're more common in adults. The two places you might see it in a kid is going to be the inguinal, which is going to be in their groin, or umbilical. And what Walter described in terms of the strangulation, so like part of the abdominal intestines poke out through the muscles, and then they don't get enough blood flow, or they can end up not getting enough blood flow. So then they're called strangulated, because they're not getting blood flow. They're like you're strangling the abdominal contents. So that is more of an emergency that requires immediate surgery. So they don't always develop strangulation. Sometimes they can just pop out. If you can push them back in, then they're called reducible. So like an umbilical hernia, you kind of see it poking out, and then you touch it and it goes back in. So if they're easily reducible, it's usually not a big deal, especially when it's umbilical. They don't always necessarily need surgery, but you do need to monitor them, and they can become strangulated, which is when they don't get the blood flow. And in the case of strangulation, they always require surgery. So they have like vomiting and abdominal pain. And like I said, if there's any concern about strangulation, then they do emergent same-day surgery. So Walter, I bet when they saw that, you went to surgery that day.
Oh, yeah, yeah, same day.
So those are all the things that you can be born with. So hernias can be congenital or acquired. So congenital present at birth or acquired, you develop them later in life. We're going to move on to non-congenital problems with your GI tract. So gastroenteritis, I'm sure you guys have all heard of that, vomiting and diarrhea. So colitis is just inflammation of the colon. And enterocolitis is inflammation of the colon and the small intestines. So you can have diarrhea for a couple reasons. That can be, viral or bacterial. It can also be, food intolerance, overfeeding, making formula the wrong way, or high amounts of sorbitol in your diet. Does anyone know what sorbitol is? So it's a type of sweetener. Sometimes you'll have food that is sweetened with sorbitol. So sorbitol in particular can cause diarrhea. And you're always going to be worried about fluid and electrolyte imbalances and or failure to thrive in someone that has diarrhea, a baby child that has diarrhea. So, the main thing if they have diarrhea is to figure out why and then treat the cause. And then also focus on their fluid and electrolytes. So as a nurse, you're going to be making sure you do good intake and output, monitoring for dehydration, and talking about, proper hand hygiene, safe storage and handling of food, cleanliness, preventing infection, etc. And then vomiting. Actually, I'm going to go back to the diarrhea. So the two sorts of things that you think about with gastroenteritis are going to be vomiting and diarrhea. So they both cause acid-base imbalances, but they don't cause the same one. So does anyone know, what does diarrhea cause? Does that cause a metabolic acidosis or a metabolic alkalosis?
Alkalosis.
I think that Reese whispered something. What did you say, Reese?
Acidosis.
Acidosis. So one of the things that when you have diarrhea, you lose bicarb. So you have base out the butt is how phrase that I've learned in my lifetime. So you're losing base through your stool. And if you lose base, you develop an acidosis. Whereas vomiting, what are you losing when you vomit? Obviously, you're losing your stomach contents. You're losing hydrochloric acid. So you're losing acid, which results in an alkalosis. So that's not like an uncommon NCLEX sort of question. NCLEX are HESI to being able to recognize, the difference in your acid-base balance based on if you're primarily vomiting or primarily having diarrhea. So I would try to remember that. So diarrhea is a metabolic acidosis and vomiting is a metabolic alkalosis. So in addition to infection, feeding too much can cause vomiting. We've talked a lot, when you have increased intracranial pressure, it can cause vomiting. And when you vomit, you're at risk for aspiration pneumonia. So with both vomiting and diarrhea, you're worried about maintaining their hydration status and making sure that they have a good acid-base balance and fluid electrolyte balance. So, in terms of improper feeding, not feeding the baby too much, burping them frequently. You can put them on a little bit on their side. So if they vomit, they don't aspirate. They might need IV fluid. And then if they are vomiting, you're going to have them stop vomiting and allow their stomach to rest before you really start introducing foods. So with diarrhea, if they're not vomiting for diarrhea, you're more likely to try to replace their fluid with liquid. Whereas if they're vomiting, you're more likely to go right to an IV. So if you're the nurse, you got to make sure that you're documenting everything very accurately, how much they vomited, what it looked like, the amount, if you gave them any medications, and if the medications had any effect on their vomiting. So diarrhea is not uncommon in kids. It's considered chronic if it lasts more than 2 weeks. So diarrhea is not uncommon, and sometimes kids will have diarrhea for like 5 to 7 days, and it's really something that really concerns parents. But if they don't have signs of dehydration, it's usually okay for them to stay home. It can be viral, bacterial, or parasitic. And I said previously, the main thing is that when you have diarrhea, you're going to be keeping track of their hydration status and then making sure that they're adequately hydrated and their acid-base electrolytes are in order. So some symptoms, obviously diarrhea. They might refuse to eat, lose weight. They could have a fever. They might be listless. It lists some things here that you would see for dehydration. So sunken eyes, a sunken fontanelle, dry skin, dry mucous membranes, not urinating as often. And then on the other end is going to be constipation. So constipation is obviously, you guys all know, you're not passing stools on a regular basis. Generally in kids, you do, diet modification before you start any laxatives or enemas. So you want to make sure they're getting enough fiber in their diet, they have enough water in their diet, sometimes doing like poop training, trying to get them to sit on the toilet at certain times and maybe read a book or something. So it's specifically defined as fewer than 7 bowel movements in a 2-week period. So it is important to remember that kids don't have to have a bowel movement every day, but really every other day they should be having a bowel movement. And then it's the same thing, you need to be documenting everything, what it looks like, how often, how hard is it, what color is it, any medications they're taking. And like I said, you normally start with increasing fiber, also maybe increasing water. And then if that doesn't work, then you might start with a stool softener. So based on other things we've talked about in class, why do you think that kids are more likely to get dehydrated than adults? What's different about kids versus adults?
Their stomach is smaller. I mean,
Yeah,
their
that's
body's
one.
smaller, so
Their kidneys don't absorb as
Kidneys.
fast.
Right. So they don't have the same ability to filter because their kidneys aren't fully mature. And they actually have a higher body surface area. So they lose more fluid through their skin than adults. So they have more fluid loss, and they also have immature kidneys. So for those are the 2 main reasons that they are a higher risk for dehydration than adults. And so it's important to remember that kids can get dehydrated quickly. And so you need to be paying attention to vomiting and diarrhea because they can look okay up until the point that they really don't look okay. So just to remember that they are more susceptible to dehydration. So you need to pay attention if they're having vomiting and diarrhea that could lead them to become dehydrated. So you generally speaking will see signs of dehydration once they've had like a 4% fluid loss, and severe dehydration is considered a 10% loss. You almost always start with oral fluids, but obviously if they're vomiting constantly and they can't keep anything down, then you're more likely to try to have them come in and get IV fluids. So dehydration is, not an adequate circulating volume. But you can have different types of dehydration, and these are going to be similar to, like, when you think about these, you're going to be thinking about like the types of IV fluids. So isotonic dehydration, hypotonic dehydration, and hypertonic dehydration. What do you think that isotonic dehydration is?
is it the normal saline like regular?
Yeah. So normal saline is isotonic. So in isotonic is that you're losing both fluid and electrolytes, and you end up, so you would treat isotonic dehydration with isotonic fluid like normal saline. And then how about hypotonic dehydration? So this would be, it's not very common. This would be like you would be losing more solutes than fluids. So you would have you know, blood that didn't have enough sodium in it. Like you would expect to have like a low sodium in a hypotonic dehydration. And then hypertonic would be the opposite, where you're losing more solute than fluid. So you're gonna, you know, treat your dehydration with IV fluid, and you're gonna target your IV fluid based on the type of dehydration. So you're gonna have to look at their labs to see if it's isotonic, hypotonic, or hypertonic. So, and this is kind of getting at this. So children with hypotonic dehydration are at risk for water intoxication. So if someone has hypotonic dehydration, you're not going to ask them to just drink free water, because hypotonic is going to be like a low sodium in your blood. So, you know, this is kind of why it's important to think that they're dehydrated, but then also you're looking at their electrolytes. So just to kind of think about that, you know, as a hypotonic dehydration, you would be giving them IV fluid that has some solutes and sodium in it, and you wouldn't be asking them to take free water. Generally speaking, if they have a slightly lower potassium, you're going to really wait until they're peeing normally before you start replacing the potassium, because your kidneys secrete your potassium. So sometimes, you know, their urine output could drop off, and then you've given them potassium and they can't get rid of it, and they could end up with a hyperkalemia. So if you're dealing with dehydration and electrolyte imbalances, you're going to hold off on giving any potassium until their kidney function is normalized and they're peeing on a regular basis. So the opposite of dehydration is going to be overhydration. So that's when you consume too much fluid. It's, you know, dehydration is much more common than overhydration. But you can imagine if you've taken in too much fluid, you're going to have more edema, etc. So you can have, you know, dehydration just from drinking too much water. You can have water intoxication. You can also have a patient that has been received too much IV fluid, and that's why they developed overhydration. So you would expect, you know, generalized edema, maybe some crackles in the lungs because they have too much fluid on board. And it's going to be the same thing, you know, you're going to be monitoring their electrolytes. You're going to be thinking about what type of overhydration is. So the same thing, like if they're hypotonic, you're not going to give them plain water. If they're hypertonic, you're not going to give them something like tomato juice or something that's salty, because they already have too much salt in their blood. So just thinking about, you know, whenever there's a problem with either dehydration or overhydration, it's not just their fluid status, it's also their electrolytes and their acid base. And you're going to be developing, you know, the medical team is going to be targeting the therapy based on their acid base balance and their electrolytes. So for overhydration, obviously monitoring for edema, monitoring their weights, and then monitoring their labs. So in addition to all of the other things that we talked about in terms of your GI tract, you can have failure to thrive, and that can be related to something going on with your GI tract, or it can be that the parents are not giving them enough food. So physiological failure to thrive would be something like a malabsorption syndrome. There's something wrong with your GI tract, or maybe congenital heart disease. And non-organic would be parents are mixing the formula wrong. They're not giving the correct amount of food that's causing the failure to thrive. So as a nurse, if you're working in pediatrics, you are probably going to be taking care of patients that have failure to thrive. How do you think you would respond? Like if you had a baby that came in and the mom was mixing too much water with the formula, so the baby wasn't getting enough calories, how would you treat that mom? How would you react to that mom?
Well, you teach. That's when your teaching comes into play.
Yeah.
You try to teach them, you know, the proper procedure for that.
You just know
Yeah.
everything, huh?
Yeah. So it's really important that you're non-judgmental, right? So you know, you don't ever want to accuse the mom of being a bad parent or making the mom feel bad or anything. This is really a teaching opportunity, like Walter said, to try to help them understand how to feed them. So it can be hard because it almost seems like almost seems like child abuse, even though it's totally non-intentional. It could be just because related to finances, they don't have enough money to buy enough powder.
Everybody got a shot today. It's happy movement.
Oh, somebody's chatting when they're not actually trying to chat. Let's see here.
Also, we see it differently. Like we check, like if it's new moms, it's different than when we have like a mom that has a couple of kids. That's when we check it more seriously, because she shouldn't be having that issue if she already
Okay.
had kids.
She should know how to feed her kids appropriately. Okay.
Exactly.
Yeah, that's
But
true.
new moms, you have to understand them a little more. They're like not used to it. They don't know what to do and stuff like that.
That's very insightful. I really appreciate you participating that way, Walter, because you work in a children's hospital, right?
Yes.
Yeah. So I really appreciate you adding that. I think even if the mom has multiple kids, it's important to try to really take a step back and be non-judgmental, because you're there to advocate for the patient. So you're going to try to help the mom through this.
We still do, but we look deeper into it.
Okay.
Not,
Yeah. Yeah, I appreciate that. So this is just kind of going over that it can be, like you said, it can be because there's something medically wrong with the child, but it can be something going on. There's not a good mother-child bond. There's something going on in the environment. You might even see things, starting in pregnancy where they don't really feel like where they're bonding with their pregnancy. So all of those things are like kind of red flags for you to think about when a kid comes in with failure to thrive. And also to remember, obviously, you need good nutrition for growth and development. So you're going to expect there to be developmental delays if you're not getting adequate nutrition. So this is another pediatric problem that you're going to really expect there to be like a multidisciplinary approach. There's going to be social work, nutrition, primary care, maybe a GI consult to see if there's something organic going on, or if there's any evidence of heart disease or anything like that, getting cardiology involved. Sort of the worst case scenario is that you might need to get the kid into foster care. Whenever you're going to have a patient that's going to be in the hospital frequently, it's really best to have like primary nursing. So having the same nursing staff that can have a better relationship with the mom and really know the mom and the baby. So, Walter kind of spoke to a lot of this. You don't want to judge the mom. You want the mom to feed the baby. Like, even if you find out that the mom was mixing the formula wrong at home and giving more water than formula, when she's in the hospital, you want her to feed the baby and to really be involved in providing care. You're going to do a lot of education and exploratory guidance. Obviously we've talked a lot about growth and development and nutrition throughout this class. So it can be really devastating long-term for kids to not get enough eat or to not be bonding appropriately with their caregivers. So this kind of affects their personality development, their language. So all of those things can be affected if they're not getting enough nutrition and they have failure to thrive. So it's not a diagnosis that you want to poo-poo. You want to take it seriously, but then also recognize that a lot of times, especially if it's like an educational thing, you can really make a huge impact in their life and give the mom or the father, whoever the primary caregiver is, the appropriate education so that they can care better for their baby. So something else that you might see that's kind of a GI related is appendicitis. Obviously, you see this in adults also. So there's some specific things with appendicitis that present differently than other sorts of GI conditions. So where do you normally see pain, or where is the pain localized most typically in appendicitis?
Right, lower quadrant, something like that.
Yeah. So it kind of starts, right? So usually starts periumbilical, which is right around the belly button. And then it gets worse within 4 hours, and it spreads down to the right lower quadrant, but it starts periumbilical and then it goes to the right lower. So if it ruptures, it's much more serious. They can end up with a peritonitis or a septicemia. And there's a couple of terms that are specific to appendicitis. So McBurney's point, that's that right lower quadrant pain. That's referred to as McBurney's point. And then rebound tenderness is something that is typical for appendicitis. It's not really typical in other GI problems. And what do you think rebound tenderness is?
Isn't it when you press on the stomach or pressing?
Yeah, so it like yeah, you press down and they don't feel pain when you're pressing, but then when you lift when you lift your hand up, that's when they feel
That's
the
when
pain.
they feel the pain.
So it's when you're not, when you're lifting the pressure up, that they have that rebound tenderness. And then you can elicit pain by lifting the thigh while they're lying down. That can cause pain. That's another thing that's, you know, kind of associated with appendicitis that you don't see in other types of abdominal pain. So, you know, when a kid comes in, vomiting, diarrhea, right lower quadrant pain, it's normal that you're going to do blood tests. You can usually, it's either diagnosed definitively with either a CT or an ultrasound, and it requires surgery. And like I said, it is going to be worse if it ruptures before the surgery. So, you know, they're going to need pain control. You know, if it was rupture, they're going to be on antibiotics for longer. You're going to be monitoring them for signs and symptoms of infection post-operatively, making sure they're, you know, doing their deep breathing exercises so they're not developing atelectasis. So just kind of think about the other sorts of abdominal surgeries that you've talked about, maybe in med surg. Those same principles are going to apply to a child that has appendicitis and has an appendectomy.
We have two
So,
types. We call one the happy appy, and the happy appy is the one that's not rupture, that, you know, we do it quick and same day surgery, blah blah blah. The one that's perforated, we keep the kids I think it's 72 hours.
Okay.
If it's ruptured, because of monitoring. But
very good.
I like the happy appies.
Yeah, the happy appies are easier for sure. So the last thing, well, I guess it's not quite the last. We're going to talk about worms, and then we're going to talk about poisoning. So worms, certainly more common in the United States, are what are called pinworms. And these look like little rice kernels around your anus. So there is what's called the Scotch tape test, and that's literally where you put Scotch tape near their anus, and when you pull the Scotch tape off, you can see the little worms on there. So this is highly, highly contagious. It spreads very easily between kids. They have to get the eggs into their GI tract. So like if a kid scratches their anus and then another kid, you know, for whatever reason has access to their fingers, or if they suck on their fingers themselves, then they're going to get their eggs, you know, they can reinfect themselves. So one of the things that you do is you make sure that their nails are short so that they're less likely to have anything stuck underneath their nails. And it's usually pretty easily treated with an anti-parasitic medication, but it does, like, it can go through daycare, as it can be spread between multiple kids. The main thing is their anus is really itchy. And more serious are going to be the roundworms. So you see this more commonly maybe in migrant communities, migrant farm workers. So that eggs are in the stool, and then they can survive in the soil for several weeks. So if the child's out digging in the dirt or anything like that, they can unintentionally ingest the larva or the eggs. So kids with the roundworms can really be very sick. They can have very, very high fever, lots of gastrointestinal problems. It's like I said, it's not as common as the pinworms, but it is treated with an anti-parasitic medication also. And you start thinking about this more if they've been playing in the dirt, or if maybe they don't have indoor plumbing and they have like an outhouse that they have to use. There's some reason why there would be the eggs in the soil. So, you know, regardless of whether it's pinworms or the roundworms, you know, good hand hygiene, and, you know, making sure that you're doing good food handling and preparation, and then, you know, not really letting kids dig in the dirt too much or eat dirt. So the last thing that we're going to talk about in this GI section is poisoning. So obviously the younger kids are, the more they are, you know, exploring and trying to open things, the more likely they are to unintentionally poison themselves. So just doing a lot of anticipatory education about locking medications up, making sure they're not in reach of children, making sure that like the kitchen sink, wherever you keep your cleaning supplies, that they can't access those. So sort of the general thing that you're going to try to do is, you know, remove the poison if they ingest something. So you prevent further absorption, call the poison control kind of center. And then any concerns at all, then you would need to have them come into the emergency department. So there are certain things that you can suspect about how vomit smells in terms of what they might have consumed. I don't think you need to memorize this chart. I would mainly remember that, you know, what the vomit looks like, what the vomit smells like. If they've had some sort of ingestion or poisoning, can give you indication about what they might have taken. And always, 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 when you consider or you're thinking that they might have had an accidental ingestion or poisoning, that you're going to be calling poison control. So I would tell parents, always have the poison control phone number. This is a national number, so anywhere in the United States, you can call that 800-222-1222. And there are people that answer that number are very, 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 very knowledgeable. They'll be able to walk parents through about, you know, do they need to go to the emergency department, et cetera. They can sometimes give activated charcoal to bind whatever they've taken. But just remember with gastric lavage or activated charcoal, you know, if it's been more than an hour, it's ineffective. That whatever you've ingested has moved through your stomach, so it's no longer going to be effective for either of those interventions. So I think, you know, a lot of times parents think since they bought something over the counter without a prescription, so that means that it's not that dangerous, but, you know, Tylenol can cause liver failure, Benadryl can kill kids. So just always make sure that you know that parents understand that even over the counter medications really should be locked up and not be in the reach of children. And also be thinking about things like oral supplements and not just medications. So, you know, kids can get into household cleaners, medications. They can also be bitten by a snake. They can have contact with a poisonous plant. They can be stung. There's lead poisoning. Who can tell me where kids normally ingest lead? Like, what is a risk factor for developing lead poisoning?
That's old paint.
Stuff.
Old paint chips. So like the older homes in like usually more like inner cities or the older buildings where they use lead-based paint. Very good. So why do we worry so much about lead poisoning? Why is it more dangerous than maybe other types of ingestions?
Well, it goes to the brain. It's more neuro.
Yeah, it can cause permanent brain damage. So that's the main thing, is that sometimes it can kind of be undetected or it can build over time. So it is one of those things that you do worry about, especially if they're living in you know, an older building or a building where there's crumbling plaster or paint or anything like that, and they're being able to put that in their mouth. So they can test the blood level in the pediatrician's office. And then it is something that we really monitor for, and we try to do a lot of anticipatory guidance and education about, because it can cause permanent brain damage.
Can a mom transmit lead poisoning to the baby?
So Walter, I honestly don't know. So I would have to look up if lead was passed through the placenta. I mean, if it did pass through, then yes, but I will specifically look into that and I'll send you a message, okay?
All right, no, I was just curious.
No, I understand, Rod. It's a good question, but I honestly don't know if lead passes through the placenta, but if it does, then it could affect the baby.
Okay. I'll look it up too.
So, you know, one of the things that's kind of more dangerous about lead is that, it can happen over time. So you might not see any symptoms for a long time, even though they've been living in a house with the peeling paint. It settles into the soft tissue in the bones, so it stays in the body. In the beginning, they might just be a little bit weak. Maybe they don't want to eat, pale, irritable, but the later stages is when you're going to really be more concerned about the mental retardation and the nervous system involvement. So kids can obviously ingest poisons, and they can also just ingest foreign bodies. So, that age when they're more likely to be exploring the world with their mouth is when they're going to be more likely to accidentally put something in their mouth that they swallow. So, so parents a lot of times freak out when this happens, but most of the time it's going to be okay. Like 80% of when they ingest something, it just passes through their AGI tract without difficulty. It can take several days. You will ask parents to monitor their stool to see if they see it coming out. You don't want them to use laxatives or anything like that. It should happen kind of naturally. But you also want to make sure that you're paying attention to how the kid's breathing and swallowing, because 80% of the time it's fine, but when they swallow something, it could get lodged in the esophagus or the trachea, which could cause problems. So you need to make sure that if they say that they're swallowed something, a bean or whatever, that you're asking if they're breathing okay, if they're swallowing okay, and then if everything seems fine, you have them follow up with their pediatrician. But remember that 80% of the time it's going to be okay, but they need to be given the warning signs that it might not be okay. So that is the end of the GI stuff. I'm going to do the same thing where I give you guys a couple of questions that I want you to talk about as a group. One of them you might have to look up in your book because we didn't specifically talk about it. So let me put them in the chat here. And I don't know, Reese, do you want to be the spokesperson again, or someone else feeling brave and wants to talk to the whole group? What do you think? Are you willing to
Yes,
do
I'll
it
do it
again,
again.
Reese? You'll do it again? Okay, let me put them both up here.
It's gonna cost you 5 bonus points though, Professor.
Okay, very nice. So the first one is explain why infants and young children become dehydrated more easily than adults. And then the next one is, this is the one where you guys might have to bust out your textbook. So what are some nursing interventions that are appropriate for a kid that has reflux, a baby in particular, an infant with reflux? So you have 2, and I'll pay attention when you stop talking, but generally you have about 10 minutes to go over these questions as a group and then come back and report your discussion with the rest of the class. So I'm actually gonna, Reese was very brave and was willing to do it last time. Yashika, are you available to be the spokesperson?
Yes, ma'am.
All right, thank you, Yashika. So go ahead and talk as a whole group, and then Yashika, when you guys are done talking, I'm gonna have you report back to the class, okay?
Okay. Let me look at the question. Well, I know with the GI reflux, well, for peas, let me see. I know with adults, you have to sit them up. Of course, you don't feed them before they, or after you feed them, kind of keep them up, elevated.
My son was diagnosed with GERD as an infant, and we had to feed him aluminum Similac, which has like smaller molecules to digest, so his body didn't have to work so hard to digest them. And it was like $45 a can. And you have to sit him up, like completely up, to burp. And you had to wait like 5 minutes in between burping and feeding.
Don't you add like rice cereal to the formula too to like make it thicker?
Yes,
Yeah.
but you only do that once a day, and the doctor told me to do it during lunch because like it could make him feel full without actually being full, and he still wanted him to get like the calories and stuff from normal feeding.
Okay. Because
Now
I know with my
sorry,
oh,
after the feeding, don't they normally have to stay up for like a certain amount
yeah,
of time, like 30,
I
45 minutes,
Mhm.
just
I
in
know,
case of
yeah,
It
because
says
aspiration?
even with
here, it
adults they
says
have
here an
to.
hour.
Okay.
You should keep
It's
the
an
kid
hour.
up an hour.
Okay, keep them up an hour before they eat. Okay, because
Yeah.
I know with my 16-year-old, she had acid reflux real bad, and she was like on a special type of milk to help her digest it better. Also, so I think sometimes it depends on what the actual milk ingredient is. And let's see. Mhm. I'm trying to go back to the first question. I don't see it.
The
Now,
first,
with the first question,
um,
Professor had said something about how the children lose more of the liquid through their body.
they have a higher body surface area.
Right.
Mhm. Mhm.
So I feel like the conversation has started to die down. Are you guys done discussing those two?
Yes.
Yeah, okay, Yashika. Go ahead and tell me what you guys came up with in terms of why infants and young children are higher risk for dehydration than adults.
So I think that was Trinetta, I'm not sure, but the higher body surface, they have a higher body surface area, and that
Sure.
would kind of.
Yeah. So what does that mean? Like why is that important in terms of dehydration?
Well, I think okay, for me, for instance, with my infant, I know I think you can't give her water until, I'm trying to remember, is it 6 months or higher? Because I know with the cow's milk, they can't have it for like till they turn a year.
Yeah.
So when you have a parent that's mixing the formula with the water, you have to make sure they're mixing the appropriate amount, so they won't give them too much water.
Yeah.
Because with the breast milk, the water is already included.
Yeah, so that's true. But in terms of
Hello?
the body surface area,
Oh.
kids lose more fluid through their skin than adults. So that's why that
Oh.
increase in their body
Oh.
surface area is important in terms of dehydration. So they have more fluid loss through their skin. Great. And then what was the other reason that you guys came up with?
Oh, we were
What
talking about the
else
same
is
question, or we're on
different?
number 2?
They have a
No, we're
higher
still talking about that.
metabolic
Oh,
rate.
They have a higher metabolic rate. Very good. How about their kidneys?
Not
Kidney
fully
temperature.
can't metabolize because they're not mature enough.
Okay, so they don't have the same ability to concentrate fluid, so they don't necessarily, they could lose more, have less concentrated urine and lose more fluid through their urine than an adult. Okay, very good, you guys. And then in terms of the, what sort of nursing interventions would you recommend for a baby that has a reflux?
to sit them up after feeding. Don't lay them down. Kind of prop them up. Make sure they're like fully birthed.
Okay.
Don't kind of force feed them.
Ah, very good.
It's like give them small amounts at a
Right.
time.
Yeah, so overfeeding can lead to more reflux. Right. Very good. And then sometimes depending on, they would have to talk to their pediatrician, but sometimes they might thicken the formula a little bit. They might put a little bit of rice cereal in the formula, so it's a little bit heavier. And then it's less likely to kind of reflux up the esophagus, but you would never want a parent to do that without talking to their pediatrician, but sometimes pediatricians will recommend that. All right, you guys, I appreciate everyone participating in class. It makes it more interesting for everyone. We're going to do another Kahoot here, and then you guys are going to start getting ready for your quiz.
So which finding in a newborn is suggested of a tracheoesophageal fistula? Failure to pass meconium in 24 hours, palpable mass in the sternal area, visible peristalsis across the abdomen, or choking on the first feed? All right, so most of you did get this right. So choking on the first feed. So this is the tracheoesophageal fistula. This is that communication between the trachea and the esophagus. So if you're swallowing down your esophagus and then some of it falls into your lungs and you aspirate, then you could have choking on your first feed. So this is going to be something that you might see as a newborn if they had a tracheoesophageal fistula. So a child is brought to the clinic with vomiting for the past 2 days. What acid-base imbalance would the nurse expect? An alkalosis, an acidosis, hyperkalemia, or hypernatremia? All right, so most of you got this right. So it is important to remember that vomiting is going to be associated with alkalosis and then diarrhea is associated with acidosis. So you should be able to pick those two things out. So in terms of vomiting, so you're vomiting hydrochloric acid, you're vomiting acid. So if you have too little acid, you end up with a alkalosis, whereas with diarrhea, you're losing bicarb through your stool, you're losing base, which causes you to have an acidosis. So the nurse is interviewing the parents of an infant with pyloric stenosis. What would the nurse expect the parents to report? Constipation, projectile vomiting, poor appetite, or diarrhea? Right, so this is the pyloric stenosis, that's connection between the stomach and the small intestine. So they're not able to drain their stomach out their intestines. So you expect them to have projectile vomiting. So this is the, if you're ever had to differentiate between different GI conditions, the projectile vomiting is the classic sign of pyloric stenosis.
So what instructions would the nurse give to parents about preventing the spread and reinfection of pinworms? Keep the child's nails short, dress the child in loose fitting underwear, clean the bathroom with a bleach solution, or wash the bed linens in cold water. Right, so this is I mean, I understand why you would be drawn to this. This is the one where they have to ingest the eggs. So you want to, keeping their nails short so nothing can really stay under their nails is one of the main ways that you prevent them from spreading the infection. So a 2-year-old child experiences constipation frequently. Which food would the nurse recommend for the child? Cooked vegetables, pretzels, whole grain cereal, or yogurt? All right, very good. So the cooked vegetables aren't going to have the same amount of fiber. You're kind of cooking out raw vegetables would help with constipation, but not the cooked vegetables. So the whole grain cereal is your best answer. So a mother calls the PCP office because your child swallowed dishwashing detergent. What is the most appropriate action? So induce vomiting by giving the child the syrup of ipecac. Give the child activated charcoal mixed with juice. Have the child drink milk to soothe the mucous membranes, or bring the child into the emergency department. Yeah, so you don't want the mom inducing vomiting at home or anything like that. What if they do activated charcoal or some sort of gastric lavage, that would be done in the emergency room. You never want the mom trying anything like that at home. And then, you're not, you don't want to give them any milk. That's not really addressing their problem. Detergent can be very, very caustic. It can cause like damage to the esophagus, etc. Those Tide pods that look like candy are especially dangerous. So this is one that if they swallow dishwashing detergent, it's best for them to just come into the emergency room. So the nurse has reviewed dietary restrictions for celiac disease. Which grain will the nurse advise that celiacs can eat? Wheat, rice, barley, or oats?
Can't.
That they can eat. They can't eat very much. There's lots that are off their list, but one thing is on their list that they can eat. So they can eat rice. So wheat and barley for sure. Technically oats don't contain gluten, but they're almost always contaminated with gluten. So you'd have them not eat wheat, barley, and oats, but rice is something that is on a celiac can eat. So why are infants more vulnerable to fluid and electrolyte imbalances than adults? A greater percentage of the infant's body water is extracellular. Water needs and losses per kilogram are lower than in adults. They have a smaller surface area, or infants have a slower metabolic rate. So this one was tricky. So it is true that they have a higher percentage of their body water as extracellular. So this is part of the reason they actually have a larger body surface area in proportion than adults, and they have more of their extracellular fluid as water. So they lose more fluid through their skin. All right, I think this is the last one. An infant has severe dehydration. Their laboratory results are 732, PaCO2 of 40, and a bicarb of 21. What acid base imbalance is this? All right, so you got bonus points for this one. So we'll start with the pH. So what's a normal pH? I think Reese.
735 to 745.
Very, very good. So 735 to 745. So a 732, is that high or low?
That's low.
That's low. So so if it's low, then that's an acidosis if the pH is low.
Mhm.
And then what's a normal CO2?
35 to 45.
35 to 45. So is the CO2 high, low, or normal?
Normal.
It's normal. And then what's a normal bicarb? Does anyone remember what a normal bicarb is?
22 to 26.
So this is high, low, or normal?
Low.
Is low. So if you have too little base, the end result is an acidosis. So this, like I said, this is tricky, and we didn't go over all of the basics, but I wanted to put it in there for you guys to be thinking about. You know, you'll see acid-base interpretation also in med-surg, and then to remember. So we said that vomiting, is that a metabolic alkalosis or a metabolic acidosis? Vomiting.
Acidosis.
So vomiting is alkalosis, and then diarrhea is what? Acidosis.
Acidosis.
So if you have this kid with a metabolic acidosis, do you suspect vomiting or diarrhea?
Diarrhea.
Diarrhea. Very good. All right. Podium time. All right, Samantha, good job. Reese. Caitlin, very nice, Caitlin. Very, very good. Okay, so I'm going to give you guys just like a 10-minute break to kind of clear your mind. So come back at like 11:05. And when you come back, your quiz will be up and you can take your quiz. And then when you're done with your quiz, you're free to go home. Okay, I'll see you guys in a few minutes. Okay, everyone, so welcome back. Go ahead and flip your cameras on as soon as you come back into class, and then you guys go ahead and take your quiz. I'm gonna wait till the cameras are all back on before I say go. Thank you. Let's take a look here. 2 out of 2. All right. So I'm just doing this so that I can keep track of the cameras on my recording. So go ahead and start your quiz. If anyone has any questions, let me know.
Can we take the quiz?
Yes, go ahead. Yep, go ahead, Walter.
All right. Going to sleep. Okay, Professor, I'm done.
All right, sounds good, Walter. You can go ahead and log off. Have a good day.
Thank
Bye-bye.
you. Bye.